Okay, you can see my presentation.
Yes, we see you.
Okay, thank you very much for the invitation to this virtual symposium, and my best greetings to our friends in Vietnam. Hope to see you back again in your country soon, so we can do a congress again in your country. My topic is gender differences in acute coronary syndromes. I will give you some causes for differences, different pathologies, and also speak about different outcomes. Let me begin with a very old slide. We could see from this slide that already in 1984, there was a sharp decline in cardiovascular disease mortality in men and an increase in women. This continued until the last century. And new dates we have from 2019 now. On the left side, you can see that there is a slightly decrease for the blue columns for men over the years for hospitalization for acute coronary syndromes, but a strong increase for women over the years until 2013 with hospitalization. And also in a study from France, there could be seen that for younger women, there is an increase for acute coronary syndromes for 6% in 10 years for the hospitalization. If you look at an American registry, the in-hospital procedures also were different in male and in female. There were less invasive procedures for women, more non-invasive testing. There was less. Now I have this the lecture from Paul Vogt on my screen. Could you please return my yes, so maybe, can you see it again?
Kannst du deinen Bildschirm nochmal freigeben?
Siehst du was jetzt?
Noch nicht? Gib nochmal deinen Bildschirm unten frei bei Zoom.
Okay.
So, jetzt kommt's.
So, jetzt kommt's, okay.
Ja, ist da jetzt den Bildschirmmodus, den Präsentationsmodus? Oder?
Ja, bin dabei. Okay.
Warte. Kommt jetzt, super. Weiter.
Okay, thank you. I told you that there was let's go back. That there was a less invasive strategy for women than in male. Also, with acute invasive procedures, there were less PCI in women than in men, and also the coronary artery grafting was much less than in male. Therefore, we can see in this large study from the ESC that there is a differences in mortality. We can see that for men with STEMI, you have a 30-day mortality for 4.3, and for women, we have a 30-day mortality for 10.2. Overall mortality was 5.8. So what are the causes? We know that one of the causes are the different sex hormones over lifetime. Here you can see, of course, that there's a sharp decline from estradiol in the menopause for women and a slightly increase for androgen for women in this time, whereas testosterone only is slowly decreasing over the lifetime of men. Of course, we know that these hormones have different effects on atherosclerosis, thrombus formation, vasoactivity, and vascular apoptosis. This leads to a different pathology. If we have an estrogen decline and an androgen increase, that leads us to a hyperandrogenism, and therefore we have some influences on the insulin resistance and the compensatory hyperinsulinemia, and that leads us also to a more pro-inflammatory state, and also a change in body distribution and insulin sensitivity. Overall, that leads on the one hand to more glucose intolerance, more diabetes type 2, and on the other hand, vascular effects for more hypertension and more of these cardiovascular diseases. There are other strong influences for the effects for women. There is a strong association to depression. Hypertension is more common in women with ACS than in men. Smoking is a stronger predictor in women than in men. Diabetes has a higher risk for diabetic women than for diabetic men. There's a higher prevalence in younger women with ACS. Kidney disease has some influence, and of course, pregnancy-related risk. We all know that if a woman has a gestational hypertension, there is a high risk for later hypertension and also for diabetes. Also, the history of preeclampsia is a high risk factor. There are specific risk factors, in female-specific risk factors, like polycystic ovarian syndrome. There is a premature menopause. There is a rheumatoid arthritis and also lupus erythematosus. We know since 1909 from a study from Gold that the female pattern of coronary heart disease is different. They have women have smaller vessel diameter, have coronary ischemia with non-obstructive coronary heart disease more often, microvascular coronary disease, small vessel disease we call that, diffuse coronary manifestation with worse prognosis and less calcification than men, more soft plaques, and the disturbances of the vasomotoric regulation of the vessels. So in the upper line, you can see that the coronary heart disease is more diffuse atherosclerosis, while in men it's predominantly focal stenosis. The different clinical appearance in men and women, we can see with the coronary, acute coronary syndromes, 3 differentiations. There is the STEMI, ST elevation, myocardial infarction, and STEMI, non-ST elevation, and now a third one, the MINOCA. I will speak about that. There are some characteristics in the differential diagnosis, which we have always to look at. I go over this for the sake of time and come to the definition of the MINOCA. MINOCA is a myocardial infarction with non-obstructive coronary arteries. That is an angiographic diagnosis. So if you have signs of a troponin positive situation and you do an angio and there is a non-obstructive coronary artery disease below 30 or 50%. This is the definition of the MINOCA. You have to look at other reasons for the troponin positive situation, like pulmonary embolism, cardiac contusion, and other non-cardiac reasons like renal insufficiency. And then you have to do a workup for these disease. MINOCA pathologies are often a plaque rupture, a plaque erosion, a thrombosis. SCAT is a spontaneous coronary artery disease, and that leads to this results of a non-obstructive myocardial infarction. We have it in 1 of 8 women with myocardial infarction have MINOCA, about 5% of all myocardial infarctions. There's a mortality about 5.7% overall in 12 months. It's not a harmless disease. And 25% have recurrent angina in the first year. The standard therapy is differentiated and has to be adapted to the situation, but normally CSA inhibition, beta blockade, and blood pressure medication. There is a controversy at the moment about a dual platelet therapy. This is an example, a 30-year-old woman, we came to the emergency department with this ECG, signs of acute ST elevation myocardial infarction. The ECG changed very quickly. The ST elevation was not seen in the further time. And in the angio, there were no signs of obstructive coronary artery disease. So we did an OCT, and we could see that there was a small plaque rupture, as you can see here in this area, and with a small thrombus building. So this was the reason for the elevation of the troponin. There is now a hint for the workup from the ACC. For this situation, normally you do a coronary angio and also a ventriculography. You do your diagnostic guide wire and do your adenosine test for FFR and also the index and the flow reserve. And then you can work up until you do a vasoreactivity test with acetylcholine. We did this in former times, not began yet. So this is the proposal for the work up here. So you can say you have a non-cardiac pain, epicardial vasospastic angina, microvascular angina, or another reason for this situation. Let me come back to the specific pathologies. The normal pathology seen in the upper pictures here is the type A myocardial infarction with a thrombus, plaque rupture, and occlusion of the vessel. This is predominant for men. Women have often a SCAT, as I told you before, a spontaneous coronary artery dissection with an intimal tear and hematoma, and as seen here. What is SCAT? It's a non-traumatic, non-iatrogenic, non-atherosclerotic separation of the coronary artery wall by intraluminal hemorrhage, creating a false lumen with an intimal tear. It's a very difficult situation to manage because you can, if you do an intervention, you have problems sometimes to come in the true lumen, and so you can have many problems for putting a stent in this situation. There are some specific angiographic signs. which we have to learn from the angios. Here is from Saw differentiation in three different angiographic signs, and I will show you some of them in the angio. This is on the left side here. You can see this small lucent filling defect, and in the middle upstairs you can see also a very thin vessel wall, which is very difficult to recognize that this is a SCAT. Also here are some other examples which are not very easy to recognize in the angio. So one of the proposal is that if you have a SCAT in an area which is not life-threatening and patient is stable, that there is a conservative management better than acute revascularization, because as I told you before, it could be very difficult to manage and to put a stent in if you have a long dissection. Causes for the spontaneous coronary artery dissections are fibromuscular dysplasia. There are pregnancy-related reasons, and there are some connective tissue disorders which lead to more SCAT. For example, Marfan syndrome, Ehlers-Danlos syndrome, and there are some systemic inflammatory diseases like lupus, Crohn's disease, colitis, polyarteritis nodosa at Church-Strauss, and more of them, which can lead to this spontaneous dissection. This is an example. I hope you can see it. This was a young woman came to the ambulance with a 1 hour chest pain. ECG was significant for anterior infarction, and you can see here that this was a long dissection from the ostial of the LAD. It was a very unstable situation, so we had to intervene in this case, and there was also already a thrombus formation. One other specific pathology, which is in cardiovascular disease more for women, is this one, which was found in Japan during an earthquake epidemic, and it is called, as you all know, this Takotsubo cardiomyopathy. The name derives from this pot from these fishermen's, and you have a specific signs in the angio, in the left ventricular levography, like seen in this picture. Here are some emotional triggers. You know that the Takotsubo syndrome has the reason in the adrenic status, activation of the sympathicus. There are some reasons like some acute family disorders, some pain operations, and we have a lot of reasons which can cause these many emotional triggers which can cause this disease. Also some physical triggers. This is the typical levography on the left, but there are also atypical levographies like seen on the right. And we know that the outcome of Takotsubo is not benign. We know that there is also a worse outcome with death and cardiogenic shock. And you can see here that 30 days mortality is about 5%, and the long-term outcome is also not a benign disease. So for finish up, some cardiovascular disease mortality over the world. There was an interesting presentation in the ESC 2019. There was an age standardized cardiovascular mortality, and we can see that the greatest mortality were in the Oceania, Central Asia, Eastern Europe, and Central Sub-Saharan Africa, lowest in high-income Asia Pacific, Australia, and Western Europe. Vietnam has a age standardized cardiovascular mortality for women in the low range. But the prevalence of cardiovascular disease in women from 1990 to 2017, the greatest increase was in East Asia, Eastern Europe, and South Asia, including countries as Bangladesh and China. Greatest decrease was in Western Europe, Australia, and high-income Asia Pacific countries.